So, very good evening to everyone. I could see many known people virtually in the audience. Rajiv gave a wonderful talk, and he spoke about the tumor mutational burden, which is very important these days, and is a fad for the medical oncologists. All of them want these days the TMB. So, at the outset, I must thank Dr. Anuradha Chogle, who invited me for this session, as well as Ase, who was a colleague in Tata Medical Center for some time, also as part of the organizer. So the title that I have been given is Inhibitors of EGFR Exon 20 Insertions in Lung Cancer. And I will just take another 20-25 minutes to cover this. I bring greetings to all of you from Tata Medical Center. This is a cloudy day in Calcutta because of the cyclone Javed in the Bay of Bengal. So what I would like to deal with is the non-small cell lung cancer. What are the targetable mutations and what are the EGFR mutations? A little bit about the exon 20 insertion mutations and their profiles. How do we test for EGFR mutations? The conventional EGFR inhibitors versus the EGFR exon 20 insertion mutations, the treatment options that are available for this mutation, and how does it confer the TKI resistance in exon 20 insertion mutations, and what are the future perspectives in this? You see, the science develops around drugs. Until unless there is a targetable drug, your mutation is not important to the clinicians. So it has become important because, first of all, it is not such a good mutation to have, and there are now drugs coming up to circumvent this badness to good ones. So just to introduce you, that lung cancer is quite a common cancer, which accounts for nearly 13% of all cancers globally, and one of the leading causes of cancer mortality all across the globe. And approximately 85% of all lung cancers are the non-small cell lung cancers. So the science is evolving from a broad histological subtyping to one-size-fits-all approach. It has evolved into a more refined classification system, which Rajiv has already dealt with. And it has attributed to a lot of genetic alterations which we are looking for. And this has led to the molecular stratification for precision oncology. So what are these targetable alterations in lung adenocarcinoma? So you have specific and effective treatment strategies now to improve the progression-free survival. So different drugs have come in which increases the median PFS by a couple of months, and the pharmaceutical companies are introducing these drugs at a fair regularity to treat these cancers. So the common ones that are targetable are the epidermal growth factor receptor, that's the EGFR mutations, the ALK translocations, which is the anaplastic lymphoma kinase, the ROS1 proto-oncogene receptor tyrosine kinase, the ROS1 rearrangements, and the BRAF proto-oncogene, which is a serine threonine kinase. And there are many more other potential genetic targets which are currently under trial. So coming to the activating mutation in the EGFR gene, which is present in approximately 15 to 20% of non-small cell carcinomas. This 15 to 20% is actually figures in the West, but if you consider India and the Far Eastern countries, where the percentage is around 30%, in our center is approximately around 30%, and it is predicted to have an increased sensitivity to EGFR inhibitors in various trials. I need not go into that. My clinician colleagues will be discussing that. And these mutations are usually clustered around 4 exons, that is 18, 19, 20, and 21, which encodes for the tyrosine kinase domain. There are some classical mutations and some non-classical mutations. The classical EGFR tyrosine kinase domain activating mutations, which are seen in approximately 85 to 90% of patients, are sensitive to the EGFR inhibitors, and usually they are point mutations like L858R in exon 21, and there are variable deletions of at least 3 amino acid residues on exon 19. Del19 is the most common mutation seen, followed by the L858R. But there are many other non-classical mutations like the exon 12 insertion mutation, which is nothing but a in-frame base pair insertion in exon 20, and this confers a de novo resistance to the commonly used EGFR inhibitors. If you look at this pie diagram, you can see that 47% are Del19, 41% are L858R, so that constitutes about 88%. The rest of the 12% are all uncommon or non-classical mutations, of which about 1/5 of it is exon 20 insertion mutations. There are about same percentage of complex mutations, and there are many other uncommon mutations which are usually detected by the real-time PCRs as well as by the next generation sequencing platforms. So if you come to the EGFR exon 20 insertion mutations, which is a unique mutation, quite heterogeneous in its class, and constitutes approximately 2% of all non-small cell carcinomas of the lungs. And 5 to 10% of this is actually the EGFR activating mutation. So amongst all mutations, 5 to 10% are the exon 20 insertion mutations. And of all the non-small cell carcinomas, 2% are these exon 20 insertion mutations. So if you consider the first and second generation EGFR TKIs, they have very little activity for this. So the median PFS for erlotinib and gefitinib is about less than 3 months, and if you consider afatinib, it is about 2.7 months. So dismal prognosis if you have this mutation. And the worst prognosis is in comparison to other activating EGFR mutations like L858R or Del19. So to continue with that, this is in fact one of the earliest EGFR mutations that was identified in the non-small cell carcinoma. And as I mentioned, they are molecularly quite heterogeneous. And there are in-frame insertions or duplications between 3 and 21 base pairs, corresponding to 1 to 7 amino acids, clustered between amino acid positions of 762 and 774 of the EGFR protein. You can detect it by Sanger sequencing as well as by next generation sequencing platforms. They are in fact mutually exclusive with other oncogenic drivers like KRAS mutation in lung cancers. This is the schematic diagram where the exon 20 lies. This is 18, 19, 20, and 21, where majority of the mutations lie. Extremely rarely you can find it in exon 22, but majority of them are in these 4 exons. And our area of interest is exon 20 in this talk. And here you have the insertion mutations, which are actually insertions or duplications, as I mentioned in my previous slide. So what is the characteristic of this exon 20 insertion mutation? It is most commonly seen in Asians, particularly in women and in non-smokers. Histopathologically, it is similar to other EGFR mutations, mostly in solid variety. And these insertions are also observed in the HER2 gene. And recently, it has been seen that this exon 20 insertion mutation is also seen in a significant proportion of sinonasal squamous cell carcinomas, as well as urothelial cancers. So medical oncologists, clinical oncologists have started requesting for EGFR mutation in these malignancies as well. So There are targeted therapies which are directed against exon 20 insertions, which may have therapeutic significance in other cancer types as well. So, what are the challenges that we face when we try to detect the EGFR mutation testing? The quality and the amount of tissue available for molecular testing is an issue. Always we talk about tissue is an issue. Already Rajiv has brilliantly touched upon this aspect. The tumor cellularity in the sample, the available platforms that you have in your laboratory, the sensitivity of these platforms, and all of us know that molecular testing takes time, and turnaround time is very important, and the economies of scale is important to give quality results at affordable price. All these are factors that guide us in the laboratory to offer services to patients. So the availability of methods that we have for its detection is immunohistochemistry is simple, doable, and most of the laboratories have adopted it. But when it comes to molecular testing, you have PCR-based assays, Sanger sequencing, the gold standard,
Sir,
real-time
I'm
PCR.
sorry to interrupt, but we are running out of time. So can we please wind up in a couple of minutes?
20 minutes I had, I have finished 20 minutes. Okay, I think then in that case I have to rush through. So real-time PCR, digital droplet PCR, we have 3 mutations on the digital droplet platform and next generation sequencing. So choosing between assay PCR based versus NGS, all have their pluses and minuses. You have to adapt based on the training and the technical manpower that you have available and the resources that is available in the lab. So timing and frequency of this molecular testing, I'll not go into the details. At the time of diagnosis, of course, in advanced disease, and as and when there is resistance to first and second line TKIs, or there's recurrence or progression, you need to test for these. So EGFR mutation analysis at our center, we use both real-time as well as Sanger sequencing. We have digital droplet PCR, we have NGS, and now we have switched over to the Oncomine focus assay for lung cancers. So our percentage of exon 20 insertions in our lab of about 2,000 samples in the last couple of years, almost 4 years, it's about 3%. But reported literature is 5 to 10%. But in our series, the majority are Del 19, L858R, and exon 20 insertion is just about 3%, and others are 15%. And this 15% includes T790Ms, 797S, G719, and many other smaller ones. So the characteristic that comes out of the real-time PCR using 2 kits, we initially used the TheraScreen, we continue to use it. We also have the True PCR, which is an Indianized version of the kit, is a make in India kit. So it can detect beautifully all the mutations, and we are quite happy with this ATM kit as well. It gives it a very affordable price, and it works quite well. Factors that regulate the EGFR TKI effectiveness, I will not go into the detail. You have the oncogene addiction model, you have reduced affinity for ATP that gives rise to resistance, and as time goes by, people acquire the T790M mutation, which is resistant to both first and second line TKIs, and you switch over to osimertinib as and when it develops, and it is because of the steric hindrance at the TKI binding site due to the bulky methionine residue and restoration of ATP binding affinity to wild type receptor levels, which is the mechanistic theory of T790M mutation. So impact of exon 20 insertion on conventional EGFR inhibitors. It is because of the position of exon 20 insertion, which is towards the C-terminal end of the C helix of the EGFR. The C helix is a key regulatory element that dictates the activation of EGFR by rotating from an outward to inward position. And because of this insertion, that forms a wedge at the pivot point of the C helix, and it locks the EGFR molecules as an active conformation. And because of this, there is markedly diminishing ATP affinity or enhancing affinity for the first generation TKI. This is a schematic diagram. You can have the exon 20 insertion mutation, where you can find that you have different drugs coming in to target this. You have the exon 20 insertion TKI, poziotinib, you have mobocertinib, you have the heat suck protein 90, and you have heat suck protein 90 inhibitors. So they're all in the on the table these days as new kids on the block. So inhibitors to this, the first and second generation TKIs
Sir,
have
sorry to disturb again.
okay.
Can we please wind up
We'll,
in next
yes,
1 minute? We are running
so
out
I
of
think
time.
I will stop the next slide. Averagely, it is 100 times less sensitive to the common sensitizing mutations. And the two first generation TKIs, the second generation TKIs also become resistant to it because of the steric hindrance with the drug binding pocket. So I'll not go into the details. So the drugs, all the drugs that are there will be dealt by my clinician colleagues. So I'll just skip them. And the moral of this presentation is that this is not a good mutation to have, but now it is targetable by multiple agents, and that is the rationale of this presentation figuring in this agenda. And you can see that there are a large number of drugs now in various trials to target this exon 20 inhibition. This is a mechanism. I'll not go into the details because of paucity of time. And I think I will skip all these. So future perspective is that urgent need is to develop an ideal therapeutic agent for this, which should have wider therapeutic index, effective against the heterogeneous spectrum of mutations, safe with minimum or no dose limiting toxicities, and it should have innovative approaches with next generation compounds. So these are the new drugs, monoclonal antibodies. The take-home message, the last slide, EGFR exon 20 insertion mutations are heterogeneous both in location, size, and behavior. Most EGFR exon 20 insertions mutated tumors show poor response with first and second line TKIs. Newer targeted therapies show promise. Efficacy and safety profile of newer agents are a key concern. Acquired resistance to newer agents is a key challenge. Ongoing and planned clinical trials will try to answer these issues in the coming years. These are a couple of the references if anybody would like to refer to. This is a slide which I show every time. This is from the Ladakh. You know that this is the icy mountains. Everything that you see behind is ice. And you look at the morale of the Indian army. All of them are smiling even at minus 40 degrees. Thank you very much. In case you have any queries, I'll be happy to take a couple of questions.
Thank you, sir,
Thank
for
you
a
very
very
much.
nice presentation. We have few questions here, but we'll get back to you at the end of
Yes, yes, I'm there.
this
Yes.
talk. So